right, hello guys, welcome back to the channel. We have yet another question again from one of my students, and as usual, feel free to pause the video, try to pick an answer, and I am going to go through the question and explain why the answer is the answer and why the other answers are not correct. Now, just very quickly before I go ahead, this series where I answer questions are intended to show you how to answer questions, how to approach questions, because I see that the major problem of a lot of USMLE students is not the studying. You have done a lot of study, you know you've done a lot of work as far as studying is concerned. The problem is usually that when it comes to answering questions, you run into several problems. In this series of questions we are going to be going through, I'm going to be trying to mitigate some of those things, try to hopefully help you begin to approach questions differently, and I believe you're going to do much better by the time you learn how to answer questions properly. I hope you have your answers already. If not, take 2 seconds, I'll give you some time, pause the video, pick an answer, and let's jump right in. All right. A 50-year-old woman is brought to the emergency department after suddenly experiencing right upper and lower extremity weakness while jogging on a treadmill. Now, when you read a vignette, you must pause after the first line of the question. If you read this question like this, and I'm going to read it like the way most of you might have read it, then I can predict that you're not doing very well unless you're already way advanced in your preparation. If you do this, a 50-year-old woman is brought to the emergency department after suddenly experiencing right upper and lower extremity weakness while jogging on a treadmill. The weakness gradually worsened over the next hour, and she has had severe headache, nausea, and vomiting. The patient has a history of chronic hypertension, but stopped taking antihypertensives several months ago. She does not use tobacco, but drinks 1 or 2 glasses of wine on the weekends. Blood pressure is 230/112. Millimeter mercury, pulse is 76 and regular. On physical examination, the patient is stuporous and responds to painful stimuli only. There is right hemiplegia, right hemisensory loss, and leftward deviation of the eyes. Which of the following is the most likely diagnosis? If you read this vignette the way I have just read it, you're probably struggling when it comes to answering questions. And I'm going to give you guys the same principles I teach every student of mine. You must pause after the first line and come up with differential diagnosis. When you read any USMLE vignette, any clinical vignette, whether for the MBME, USMLE, you must pause after the first line and come up with some differential diagnosis. So, a 50-year-old woman brought after suddenly experiencing right upper and lower extremity weakness while jogging on a treadmill. A number of things come to mind before we even jump into this. I have mentioned before, those of you that watch our videos constantly, whenever they tell you that something occurred suddenly, it is either a vascular problem or what do I call it? Or a neurologic problem. Okay, take note of this for your exams. If something occurs suddenly, you either have a vascular problem or a neurologic problem. Think of it. If you suddenly have an injury to a part of the brain, say a stroke, for example, which is kind of a combination of both vascular and neurologic, you're going to have sudden onset weakness, for example, right? If someone has sudden pain, you suddenly feel something vascular. Think of something like ovarian torsion, for example. Even if with ovarian torsion, you probably have a history of ovarian cyst or something like that. But usually when things happen suddenly, you think the patient has a vascular problem or a neurologic problem. Anything you think about, renal infarction, CNS infarction, strokes, all of these things will occur suddenly. The only exception is in the lungs. Now, in the lungs, when you have sudden onset, it's usually going to be shortness of breath. When people have sudden onset shortness of breath, when it comes to the lungs, you're looking for pulmonary embolism, you're looking for pneumothorax. Because think of it, suddenly you occlude the pulmonary vessel. All of a sudden, there's no blood flow to the lungs. The patient immediately experiences shortness of breath. So sudden onset shortness of breath, you're thinking, boom, it has to be pulmonary embolism or a pneumothorax. In other cases, you may have maybe some people talk about aspiration. I don't particularly think that aspiration would present as sudden onset shortness of breath. But if you have an obstruction, maybe a child swallowed something, foreign body aspiration or something of this nature, maybe that will produce sudden onset shortness of breath as well. But for your exam and what is important for the USMLE, whenever they give you someone with sudden onset shortness of breath, you should think pulmonary embolism, pneumothorax. Heart failure will cause progressive shortness of breath. So once again, think of what I'm telling you. The language and the words they use already give you a clue as to what you are looking for. So when you read this and you go suddenly experiencing right upper and lower extremity weakness while jogging on a treadmill, you already have an idea what is going on here, and I'm sure a lot of you came up with stroke or cerebrovascular accident. Congratulations if you got that right. The weakness gradually worsened over the next hour. The weakness gradually worsened over the next hour. That is going to be important because I'm going to tell you what my students picked as her answer. And I think if she paid attention to this statement alone, she would have gotten this. She would have probably not picked the answer she picked. It gradually worsened over the next hour. She's had severe headache, nausea, and vomiting. Now, how do you interpret that line of the question? Right? How do you interpret that line of the question? You're going to ask yourself, why is the weakness gradually increasing over time? Right? Why is the weakness gradually increasing over time? And she's had headache, nausea, vomiting. Headache, nausea, and vomiting here are indicators for increased intracranial pressure. Headache, nausea, and vomiting are indicators for increased intracranial pressure. It means that something is building up in the brain. And when you think something is building up in the brain, immediately you think of what? Probably blood, right? CSF may be building up. But in a person that suddenly has weakness, you think she has a stroke. Okay, some of you may be thinking, is it a hemorrhagic stroke? Is it an ischemic stroke? Well, I don't know. But then they went ahead to say the weakness gradually worsened over the next hour. Why is it getting worse? Is it perhaps because you are having more bleeding into the brain? Is it perhaps because you're having more bleeding into the brain? So the more blood you have seeping into the brain, the more pressure that will build up in the brain, the more severity of symptoms the patient is going to manifest with, and the patient is also going to have signs of increased intracranial pressure. When you have ischemic stroke, for example, if you have infarction, right, ischemic stroke, you know, okay, boom, you occlude the blood vessel, there's no blood flow to the brain, you're going to have weakness, you're going to have all the symptoms of ischemia to the brain, but you are not going to have increased intracranial pressure because there's no blood going into the brain. There's nothing going into the brain to increase the pressure. You just have ischemia. You're going to have weakness. But when they tell you that there are signs of increased intracranial pressure, you immediately begin to think this is probably hemorrhagic stroke. If you thought of that already, you rule out option B and option C. So this cannot be an infarction. This has to be hemorrhagic stroke. But just maybe we are not sure. Let's go ahead. The patient has a history of chronic hypertension. History is important. A patient with history of hypertension, especially uncontrolled hypertension, blood pressure here is 230, probably or is more likely to have hemorrhagic stroke than ischemic stroke, right? A patient with severely elevated blood pressure is very likely to develop a hemorrhagic stroke rather than an ischemic one. They can still have ischemic stroke because they might also have severe atherosclerosis. But with a blood pressure that looks like this, it is more likely that your patient has a hemorrhagic stroke rather than an ischemic stroke. Again, helping you rule out option B and C. The pulse is 76 and regular. On physical examination, the patient is stuporous and responds to painful stimuli only. There is right hemiplegia, right hemisensory loss, leftward deviation of the eyes. Which of the following is the most likely diagnosis? Now, why will I not pick? I cannot go ahead and pick an answer straight up, right? But why will I not pick cerebellar hemorrhage here? Why will I not pick cerebellar hemorrhage here? What do you know about the cerebellum? When you think of the cerebellum, if something happens to the cerebellum, you think the patient is going to have some form of ataxia. The cerebellum is responsible for balance and coordination. So you expect to see cerebellar signs, for example. We did not see any cerebellar signs in this patient, so we know that this patient is not having anything to do with their cerebellum. So I'm going to rule out that option. I already gave us reasons why we are going to rule out infarction from this scenario, right? First of all, because it is gradually worsening. It's gradually worsening. If you cut off blood supply from the brain, can you really gradually worsen? Not really, because I mean, you've cut off the blood supply. You can't cut it off anymore, right? Think of it like that. In that sense, if someone has hemorrhagic stroke, if you're bleeding into the brain, you can bleed some more into the brain, and that will worsen the situation. So the fact that it is gradually worsening helps you rule out infarction, makes it more likely to be hemorrhagic. The fact that there is headache, nausea, vomiting helps you know that there is increased intracranial pressure. So something extra is added to the cranial cavity. What could it be? Blood, suggesting that this is a hemorrhagic stroke, not an infarction. So we can safely rule out cortical ischemic infarction and medullary ischemic infarction. Then it leaves off with putaminal hemorrhage and subarachnoid hemorrhage. For a lot of students, a lot of you that are probably watching me, you're not sure what putaminal hemorrhage really means. And this is understandable. We don't have it as a concept by itself, but hopefully would make sense of it now. My student here, she said she was kind of stuck between these two, but she wasn't sure what putaminal hemorrhage was. So she picked subarachnoid hemorrhage. Okay. I don't know how many of you out there picked subarachnoid hemorrhage. If you did pick subarachnoid hemorrhage, feel free to let me know in the comment. But what is wrong with this answer? I asked her, how do patients with subarachnoid hemorrhage present? How do patients with subarachnoid hemorrhage present? And she told me right away, worst headache of their life. Thunderclap headache. That is how it's usually described, right? The patient is going to complain of the worst headache they've ever had. Well, does this question describe anything like that? The answer is no. Whenever you're stuck between two options, this is something you need to ask yourself. How do patients with option D present versus how do patients with option E present? If you think of that alone, you may be able to rule out one of the options, like I just did in this question. Subarachnoid hemorrhage, suddenly experiencing right upper and lower extremity weakness. They didn't even talk about the thunderclap headache or anything like that. My student said, oh, but Kennedy, they said she had severe headache. I said, but that is not the point. In subarachnoid hemorrhage, the headache is the presentation. You want to know that with subarachnoid hemorrhage, the headache is if not more important than the weakness, if at all, that is going to ensue. The patient will complain of the headache. The headache is the main complaint more than any other additional symptoms that may follow. Okay, so that is important in helping you rule out subarachnoid hemorrhage. Now, for a lot of you, you will say, I did not know what putaminal hemorrhage is, so I did not pick it. This is one of those times when, for those, when you see the course on test taking mastery, one of the things I tell you is, if you've never seen something before as an answer, you've never had it anywhere before, should you pick it on your exam if you're not sure? Probably not. But this is one of those cases where you should pick it. Okay? When you have successfully eliminated everything else and you are confident in the process you have undergone to eliminate them, you can feel comfortable choosing that option you don't really understand fully. You understand subarachnoid hemorrhage. You know what cerebellar hemorrhage looks like. You know this is not an infarction, but you're not sure what putaminal hemorrhage is supposed to look like. Maybe you should pick putaminal hemorrhage because you are quite sure it is not any of the other ones. You should feel confident in yourself to pick putaminal hemorrhage. And indeed, the correct answer here is going to be putaminal hemorrhage. Putaminal hemorrhage. Okay, let's talk about the putaminal hemorrhage for a little bit. What part of the brain comes to mind when you think putaminal hemorrhage? I hope you thought putamen. I hope you thought about the putamen. What do you remember about the putamen? You may remember that the putamen is one of the structures of the basal ganglia. The putamen is one of the structures of the basal ganglia. And I have this image here to show you guys. If you remember this image from your neuro, you have the basal ganglia structures basically around here. And we have all these parts of it. We're not going to waste too much time with this. But the head of the caudate is over here, right? These are the main structures we're interested in. We have the caudate nucleus, and right here is your putamen. it's just remember that the putamen is one of the structures of the basal ganglia. And what is the function of the basal ganglia? The basal ganglia plays a role in motor control, plays a role in some language functions, and a lot of other activities that go on in the brain. Then somebody says, Kennedy, but the question did not present specifically to the putamen. One of the structures that is very closely associated with the basal ganglia and its structures is your internal capsule. You would remember that when you did ascending tracts, all your ascending tracts went to the brain via the posterior limb of the internal capsule. Your descending tracts also go through the internal capsule when they pass. So whenever you have a stroke affecting the basal ganglia, the internal capsule inevitably is going to be affected. And you remember your internal capsule, we have the anterior limb of the internal capsule, the genu of the internal capsule, and the posterior limb of the internal capsule. So once the internal capsule is involved, you're going to have weakness, upper limb, lower limb weakness, motor abnormalities, and all of those kind of symptoms. And this is basically the explanation to why the answer of this question is what it is. I hope this made sense to you. If you have any questions, leave them down in the comments. Don't forget to give this video a thumbs up. Please share to another medical student. And if you're not subscribed, please subscribe as well. I will see you guys in the next one. If you have any interesting questions that you have struggled with that you think I should see, feel free also to send me that question. I will do a video like this, talk about it, hopefully in a very short time, and help you on your journey to the USMLE. Until next time, remain, I don't know, keep crushing it, study, and I will see you guys soon.